Started, and here is your question. Right. So if you have read and understood, kindly begin your history taking.
Okay. I entered the room. I washed my hand and introduced myself to examiner. Good morning, sir.
Good morning.
And good morning, sir. Another examiner. Then I went to the patient. Hello. Good morning, Mrs. I am Dr.
Mrs.
Suman
Linda.
Kumar, one of the surgery doctors. Can I confirm your name and age, please?
Hi, my name is Jane and I am
Linda.
40 years old.
Yeah.
35.
35. Okay, Mrs. Nice to meet you. So today I'm here to ask you a few questions regarding your condition. Are you okay with that, Mrs. Linda?
Yeah, sure, doctor.
Okay, so how can I help you today?
Doctor, I am having this abdominal pain for a long time now, so I thought to get a checkup done.
Okay, so I'm really sorry to hear that. So where do you feel that pain exactly? Can you point to the side with a finger?
Yeah, it's in my tummy, above top on the tummy here.
Okay. Is it started suddenly or gradually?
It started actually gradually, but over the period of time, it became like a constant pain.
Okay. And does it comes and goes or it remains static?
No, it is on and off. It is not static.
Exactly when you did first notice this pain?
A couple of weeks back.
Okay. And is there anything which decreases this pain?
Yeah, when I take some painkillers, it decreases.
And anything which increases the pain?
Sometimes after taking food or drinks like that.
And can you describe which type of pain it is? Colicky, cramping, or a stabbing, like that?
Yeah, I can say it's kind of stabbing pain.
Okay. So this pain, how does it interfere your daily living routine?
I just can't explain. When I have this pain, I can't do anything. Even if I take breaths, it
I'm
feels like
really
horrible.
sorry to hear that. If you must rate this pain on the scale of 0 to 10, where 10 being the worst pain you can imagine, how do you rate it?
It's variable, like 7 to 8 or sometimes 9 even.
Okay. Okay. Does it move anywhere, like in the back or over the shoulder, any right shoulder?
Yeah, in the back. Sometimes it goes in the back between my shoulder blades.
Okay. Okay. I'm sorry. Okay. Have you noticed any yellow color of your eyes?
No, I don't think so.
Okay. Does this pain increases by fatty meal?
Yeah, yes,
Okay.
it does.
And does it relieved by when you lean forward?
Oh, yes, doctor. Yeah, it helps a lot.
Okay. 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 So do you have any chest pain or have you got any investigation for cardiac problem before?
No, I know.
Okay. Did you vomit, throw up?
Yeah, sometimes.
Okay. Okay. And was there any blood in the vomit?
No, doctor.
Uh, did you feel any heartburn?
Sometimes I do feel heartburn.
Okay. And you noticed any blood in the stool?
No.
Have you got any trauma in your tummy recently?
No.
Okay. Have you had any surgery in the past for any illness?
No.
And have you admitted for any medical illness in the hospital, or got any medical problem right now or in the past?
No, doctor.
Okay. Do you take any medication right now?
Yeah, I take sometimes strong painkillers, sometimes.
Okay.
Okay. As well.
Do you have okay. Do you have any drug allergy?
No, I don't have.
Okay. Before I proceed, do you mind if I'll ask you some personal questions?
Sure, doctor. No worries.
And does anyone in your family have had similar problem like you have right now?
No.
Okay. And did you drink alcohol?
Yes, I do.
Okay. How much?
2 to 3 beers a day.
Okay. Do you smoke, Mrs.
Yeah.
Linda?
Yes, I do.
Okay. How much?
1 packet a day.
1 packet a day. What about your menstrual period? When was your last menstrual day?
Regular, no problem.
Okay. And what do you do for living?
I'm a teacher.
Okay, that's nice. And whom do you live with at your home?
I live alone.
Okay. Do you feel any difficulty in going upstairs using the stairs?
Yeah, sometimes when I have pain, I prefer to stay in the bed.
Okay, Mrs. Linda. I now placed my question. Do you have any question or any ideas or any worries or anything especially want to expect from us? You are expecting from us, other than we have just discussed?
No, nothing special. I just want to know what's going on with me and how to solve this issue.
Okay. Thank you, Mrs. Linda. I'll discuss the case with our team and consultant, and for the steps, so you will be updated accordingly. Okay. Thank you. Have a nice day. Then I'll wash my hands.
Can you summarize your case now?
Okay. This 35-year-old lady, Mrs. Linda, who is working as a school teacher, she presented with pain of epigastric region, which is radiating to the back and have a severity of 7 to 9, depending on out of 10. And she's having pain after taking meal, especially fatty meals. And she had previous episode of 3 episodes of vomiting. She takes about half a bottle of vodka every day, and she also smokes about 1 packet of cigarettes every day. And their pain gets relief on leaning forward. It does not radiate to any other side other than back. It radiates to the back.
What are your differential diagnosis?
On the basis of the history, my differential diagnosis is acute pancreatitis, either due to gallstone or due to alcohol excess. For further diagnosis, I'll do the complete history as well as the clinical examination of the patient of abdomen.
Okay.
I'll also consider the differential diagnosis of biliary colic and alcoholic gastritis, gastroesophageal reflux disease, or cholecystitis.
Okay. How do you plan to manage this patient?
After taking further history and clinical examination, I'll advise the patient some lab investigation and imaging investigation. Initial blood investigation, I'll advise complete full blood count, urea electrolytes, liver function test, serum amylase, serum lipase, calcium, LDH, and liver enzymes, glucose, C-reactive protein, arterial blood gas analysis, coagulation profile, and blood grouping cross matching. And then I'll advise the imaging for ultrasonography, CT or MRI. Also advise for MRCP and endoscopic ultrasound if required. Hello.
Yes, please.
Yes, ma'am.
I'm sorry. Yes, please. What treatment can you offer this patient?
I'll do the primary resuscitation or primary assessment of this patient as this protocol in ABCD format. I'll start oxygen, cardiorespiratory monitor, get IV access and fluid resuscitation. I catheterize the patient, start fluid and keep patient kneel by mouth.
Okay.
Then after sending the blood investigation.
Sorry, time has bell has gone, but then just tell me the solid points that you'll be covering. Okay, this is the medical treatment that you are offering. Then what else would you consider?
Other than that, monitoring and that, and then I'll give the octreotide, and if a patient does not get relief from the medical treatment, I'll discuss the.
Yes, regularly was taking morphine, so morphine is addictive. Would you consider referring any request to any psychiatrist, psychologist?
Yes, I'll take the consultation with the psychiatrist for for her regular morphine taking. That is maybe addiction or she's addicted.
And she also told you that she's using tobacco, so maybe that also needs to be reconsidered.
Yeah. Yes, ma'am.
Okay.
For psychiatric evaluation. Yes.
Any nutritional measures that you are going to take for this patient?
Initially, I'll keep the patient kneel by mouth and start total parenteral nutrition.
Yes.
And then when patient will relieve from the symptom, I'll advise her not to take a fatty meal, avoid those meals. And yeah, that's
okay. What else would you do? Here, patient is also diabetic. You'll make sure.
Yeah,
all this.
Yeah,
I'll
take the consultation of the diabetologist also, endocrinologist for management of this diabetes. I'll see if patient is having any diabetic ketoacidosis or
that you should have
diabetes.
Maybe in third or fourth point in differential diagnosis. Like you should consider that, considering the condition of the patient, and also taking morphine. Withdrawal could be there. I don't know, because patient is having abdominal pain, so BD could be anything anyway. Okay, good. All right.
But diabetes can cause abdominal pain.
Yes, when uncontrolled. We don't know the condition, you know. But then that may not it may cause even vomiting, uremia, you know, but then
vomiting, yes.
6-2-WC, no, that is
it can cause
pancreatitis. But toxic eating, drowsy can also be uremic. Yes, I've seen people being very drowsy. Depends on the woman. Okay. All right, so that was about it. What is last question? What is the role of surgery in pancreatitis, if any?
We'll do the ERCP and sphincterectomy.
When?
And if pancreatitis, if there is a development of pancreatic abscess, pseudocyst, then we'll
when
we'll do the either percutaneous, percutaneous drainage or open drainage.
Yes. Good. Thank you. Yes. Okay, started the timer, and here is your question. Right. If you have read and understood, considering it critical care scenario, kindly tell me how would you manage this patient?
I would manage this patient by ABCD protocol while
Very good.
care of critical surgical patient.
Yes.
I will maintain patent airway, breathing and circulation. Airway, I will look for, look, feel and listen and maintain oronasopharyngeal airway by chin lift, jaw thrust. And if it require ET intubation, then breathing will see for the chest wall expansion, do mini fast chest examination, check trachea centralization, SpO2 and FiO2 monitoring. Then I'll then proceed with if the intervention require, insert the chest tube, insertion will be done. Then I will
What
go
are your
ahead for
provisional
the circulation.
diagnosis for this patient? What has happened?
This will be pneumothorax.
So how would be the
Simple or
airway?
tension.
Yes. How would you find airway when there is pneumothorax?
There will be tracheal deviation if there is
Deviation,
tension
very good.
pneumothorax.
Yes, yes. So,
And there will be reduced
yes.
chest.
How would that affect
Yes, ma'am.
breathing of the patient?
There will be reduced chest wall movements on that side and tachypnea.
Okay, good. So can you tell me, okay, how would be the, okay, so can you please tell me what are the types of pneumothorax?
Simple and tension, ma'am.
Okay. How would you differentiate between tension and simple pneumothorax?
Simple pneumothorax, there is no tracheal deviation, while the tension pneumothorax has tracheal deviation to the opposite side. And then there is on the, yes, ma'am.
Yes, what else? After tracheal deviation, there'll be something more as well. Would there be any cardiovascular compromise? If yes, and
yes,
in
tension.
which type? Okay.
Yes, tension pneumothorax, there will be cardiovascular compromise because there is mediastinal shift. So there will be next
yes, leading to cardiogenic
congestion
shock.
of the neck.
Yeah.
Cardiogenic shock, yes.
Okay, yes. Okay, can you please tell me what do you understand by the term safe triangle?
Safe triangle is a surgical landmark used for the insertion of the chest tube, which is marked anteriorly by the posterior lateral border of pectoralis major muscle, posteriorly by the imaginary drawn line that is a mid-axillary line, and the base is found by the fifth intercostal space. So the chest tube is inserted above the fifth rib and anterior to the mid-axillary line.
Very
and if
good.
it is hemothorax, the tube is inserted towards the base, and pneumothorax towards the apex.
How can you confirm your diagnosis? What investigations would you do to confirm it?
Firstly, radiological diagnosis, that is chest
Very
X-ray.
good. So if you have done what you have done the X-ray, what are you looking at? Can you help me read? Yes.
First, I will confirm the patient's name, first name, surname, and date of birth. Then
Yes.
I will. This is a plain chest X-ray, which is the erect, the chest X-ray, which is in the supine position. Then
Yes.
I'll check for the exposure.
Yes.
That is there is adequate exposure because the thoracic vertebrae are barely visible. Then rotations, the distance between the medial end of the clavicle to the transverse process of the vertebrae, it is slightly rotated to the right. Then I will check for the epiphysis and the cardiophrenic angles, which is not adequate as we cannot visualize the cardiophrenic angles on both the sides. Then I will check for the airway, that is there is tracheal deviation to the opposite side, and there is the bone appears normal. Cardiac shadow is shifted to the opposite side, and
Yes.
the lungs seem to have pneumothorax because of the increased shadow, cardiac, the lung shadow.
Okay,
right
can
side.
you please name few indications for central line?
Yes, ma'am. Central line firstly can be used for IV resuscitation, then dialysis,
Yes.
then transcardiac venous pacing, and also for monitoring of the patient.
Yes, and for TPN as well. Okay, can you name few complications of central line?
Yes, ma'am. There is technique related which can
How
cause
would you
pneumothorax.
classify the complications? Immediate?
It will be immediate
Yes.
and late.
Yes.
Immediate will be pneumothorax,
Very good.
and late will be sepsis, thrombosis. Immediate can even be chylothorax if insertion is done on the left side.
Yes.
And the tube, while inserting through Seldinger's technique, if reaches too far away into the atrium, can cause arrhythmia.
Okay, very good. Okay, can you please tell me, according to the NICE guidelines, how this central line should be inserted?
The center line should be inserted according to the NICE guide by Seldinger's technique. Firstly, pre-procedure check should be to obtain a chest X-ray with coagulation profile and blood culture to check if there is a previous infection. Then I will proceed with the patient in head down Trendelenburg's position.
Very good.
I will mark the internal jugular vein by the surface marking from the earlobe to the medial end of the clavicle. Then I will
Very good.
visualize the palpate the two heads of the sternocleidomastoid, that is sternal and clavicular head, and in between that I will feel for the carotid artery pulsation and just lateral to it insert the catheter using Seldinger technique and 30 degrees.
Okay, good. What technique or can you use to remove the central line?
That is by head down position to prevent air embolism.
Very good. Okay, can you name the sites for inserting a central line?
Yes, from head to toe, that is the internal jugular vein, then the subclavian vein, and then the femoral vein.
Yes, very good. Can you name few organisms which can cause infection in a patient which has central line in situ or in place?
Staphylococcus aureus, Streptococcus species.
And epi.
Okay, epidermidis, yes.
Okay, what measures can you advise to the patient to prevent the infection?
Firstly, absolute sterile precautions should be maintained. Absolute sterility, that is the site should be well sterilized before starting any procedure, and if alcohol based antiseptic is used, it should be allowed to dry before insertion of the catheter. The person who's performing should should have washed the hands properly before the procedure, should don a sterile gown with sterile face mask, cap, and gloves, and then should perform the procedure.
If you witness a patient developing tension pneumothorax in front of you, what would you do instantly?
Instantly would insert a bineedle thoracotomy.
Yes, where?
Into the second intercostal space along the mid-clavicular line on the affected side.
Okay. Right. Good. Okay. All right. One second. Thank you so much. It was superb.
Thank you, ma'am.
It's excellent. Yes.
Hello?
Yes. Good.
Yes, ma'am. Your voice faded away.
Yes, network. It's all over. I'm sorry.
No problem.
Good. Any questions? Anyone want to give feedback?